Hello and welcome. I'm Dr. Iliopoulos, and on behalf of Creative Educational Concepts, thank you for joining us today in this educational activity. It's called Diagnosis and Multidisciplinary Care of VHL Disease-Associated Tumors. Today's activity is supported through an independent educational grant for Merck. This activity may include discussion of products that are not currently approved by the FDA for all indications that we are going to discuss. Again, let me introduce myself. My name is Dr. Othon Iliopoulos. I'm a physician scientist. I'm an associate professor of medicine at Harvard Medical School and Mass General Brigham Cancer Institute. I work at Mass General Brigham Hospital, and I'm the director of the VHL clinic. At the same time, I'm also director of lab for cancer genetics that does research related to the VHL disease. Our learning objectives today are first, to identify the patients with VHL disease and associated tumors, to describe these patients, to understand what are the presentations of these patients, the imaging and the algorithm of the genetic assessment. And second, to examine how we can engage a interdisciplinary team of professionals for the care of the VHL patients and the care of their tumors, which is necessary these days. Let me introduce at this point a patient with VHL disease and start by discussing with him some of the life experience that he had with the disease and aspects that a patient himself, in this case, can only experience. So let me ask you the first question. Before you have, we know you have a formal diagnosis of VHL disease. Before you have this diagnosis, was there any family history of VHL or related tumors in other members of the family, or you were the first one? And what is your trip until the moment that you were told that you have VHL disease?
Yeah, no, I was the second one. And the way it transpired was my brother had brain surgeries when he was a teenager, and we were actually roommates in college, and he started having headaches and symptoms, and he ended up going to the doctor, and the doctor started thinking this is the early 90s, and they tested him for tumors in the kidney. And sure enough, he had tumors in the kidney, and they thankfully knew about VHL at that point and diagnosed him with VHL, said, your siblings should be tested. I was tested. I had a brain tumor. And so it was very lucky in a sense, but also a very difficult time for us as young men to find out that we had this chronic genetic condition that was a lifelong battle.
It's very, very interesting. So let me ask you a question. Was there any long time elapsed between the first time that your brother developed symptoms or the first tumor was diagnosed until the medical care system labeled your brother with the VHL disease name?
Yes, quite a bit of time. I think it was at least 7 or 8 years after his first brain surgery that he was finally diagnosed with VHL. In fact, I believe that if he had been diagnosed earlier and had been under the surveillance regime, that they would have caught his kidney problem much earlier, and perhaps they wouldn't have had to remove an entire kidney when they had it. And so that was a very, very important event for him. And I was lucky enough where I was able to be diagnosed and then put under surveillance quickly. And so I've had a much easier experience with it than he did.
you were diagnosed after the disease was discovered in him and diagnosed, and therefore the guidelines were to examine the other members of the family.
Exactly.
Is there any other member of the family that has VHL disease?
Yes, my mother has it. Um, we've had multiple deaths. Now that we look back into the family history, my
Mhm.
grandfather passed away at a young age. We believe that that was the case for him. His mom passed away at a young age. We feel like that was it. Our extended cousins, we know of many who have had the disease has transpired in various ways with them. And, we have even kids within the family who have it. So yes, big yes. And I am sad to say that some have died from VHL, including my brother. So whether directly or indirectly, we've had deaths in the family because of VHL. So it's quite a part of our lives.
It sounds like a quite dramatic process in the family. And if you don't mind me asking one more personal question, for you, how was your first tumor identified, or what was your first tumor?
Yeah, it was a hemangioblastoma. It was a rather small one, but with the cyst had grown and I was having headaches and symptoms. The stress of my brother having to go through a lot of things didn't help. And so I had a surgery and we removed it. This is early 90s. I was a young man and it was not fun. I had never had such an experience. And so I was very, very afraid. And I remember the time the doctor told me I had VHL, how scared I was, and throughout the surgery and so on and so forth. So it was quite a dramatic effect. Since I've had an additional three brain surgeries, radiations, eye surgery, and I've had various treatments. So
But you are now healthy, you are with us, and you are smiling, and this is very important. This is a long course. So I have to say
yeah,
that probably you um, uh, lived through the different stages, historic stages of identifying and diagnosing VHL disease, starting from a period of time that the disease was a little bit unknown, living through the navigation through the healthcare system to find a VHL clinical care center that you have been taking care the last years, and seeing actually the dawn of a new era that VHL is changing from a surgical disease into a medical disease treated with the medication. How do you feel about all this?
I feel very good because I have, not only for myself, but I have lots of family who have it. And so this is a life, every discovery, every advancement in treatment for us is a significant life event. And I have to say, I am so pleased. It's not just a medicine that has revolutionized how you're approaching it, but also the techniques in surgery. The surgeries have become a lot more straightforward. Knock on wood. I mean, it's still brain surgery, very serious, but the technology and the capabilities of the surgeons are amazing compared to just 10, 20 years ago. So absolutely delighted with and hopeful for further improvements in the future.
Thank you. Thanks very much for sharing this experience that you had with us. And let's stand by while we're going to review and put in this scenario that you told us in the context of VHL disease and review some of elements, and we'll come back to your personal experience. So let's talk a little bit about VHL disease. What is VHL disease? It's an inherited disease. It's a disease that can be passed from the one generation to the other in a lot of the cases. Sometimes it happens automatically, spontaneously, simultaneously, as we call, to an individual. It's characterized by benign and malignant tumors across multiple organ systems. And this risk for the development of the tumors, not these tumors necessarily, lasts for the whole lifetime. It happens in many organs, is multiphasic, and again is progressive. How do VHL patients present? Sometimes they are related to the family that the disease has been already diagnosed, and therefore they tested or their tumors are imaging and they found to have VHL disease. Occasionally they present with symptoms that related to the brain tumors or the kidney tumors without prior evidence of the disease. The diagnosis a lot of times is made through incidental imaging, and the findings in the imaging of the brain or the findings of the image of the abdomen are reminiscent of the disease, and a radiologist or a clinician who follows the patient can make this diagnosis. So let's take a little bit of the historical perspective. As you heard from our patient, the disease, our understanding of the disease evolve over time, and the treatment disease evolve over time. One word of caution is about the expression of the disease. Initially, the disease thought to have 100% penetrance by the age of 65. That means that by the age of 65, some manifestation of the disease clinically would have occurred. This picture is gradually and slightly changing. The reason is that patients now these days are subjected to, for irrelevant indications, to multigenic germline testing, and this diagnosis of the VHL disease as part of this, the VHL mutation in this gene as part of the multigenic testing may be what we call incidental. So the prevalence of the disease was initially thought to be 1 in 36,000 individuals that they were born, but our suspicion is this prevalence of the disease will increase significantly because of the identification of the incidental VHL. So the denominator is going to increase, and therefore our idea about the penetrance of the disease will change. There are going to be cases that, despite the presence of the mutation, the expression of the disease, the expressivity of the disease, and the penetrance is very low. That will potentially in the future reshape and inform the surveillance recommendations that currently are based on having or following VHL patients with already known existing tumors, or that they're members of the family that have been already having diagnosed VHL disease. So the surveillance for the tumors and the approach to disease is likely to change in the immediate future in more personalized medicine manner. Let's have a closer look at the type of the VHL-associated tumors. What are the patients with VHL at risk for developing? The most prevalent problem they may develop is hemangioblastomas of the central nervous system. Hemangioblastomas are tumors that develop in the cerebellum, in the brainstem, in the spinal cord, and as I mentioned before, in the retinal layer of the eye. When they are symptomatic, the patient may present with headaches, with ataxia, or sensory deficits, weakness or numbness in the arms or the legs. All these are due to the symptoms to the mass effect that these tumors exert on the brain or in the roots of the nerve. These are benign tumors. They are not infiltrating the brain, but because of the closed space of the brain, anything that grows and occupies space can compress the normal tissue and lead to the development of symptoms. Again, in the eyes, when these hemangioblastomas are presented, they're called retinal hemangioblastomas. A lot of times may be asymptomatic. That's why we have to preventatively look at the retinal of these patients. When they become symptomatic, they present with flutters or changes in the vision. if they left untreated or if they diagnosed very late when they're big, they may lead to retinal detachment and blindness. Next, the renal manifestations that we mentioned already. The patients may have renal cysts. These cysts usually are bilateral, and there are many numbers. And unfortunately, most of the times, the symptoms from the kidneys do not exist. These lesions are asymptomatic. If these lesions, if the tumors in the kidneys grow big, they may give pain in the side or hematuria. And if they grow above 3.5 centimeters, they may metastasize out of the kidney and really threaten the life of the patient. So the early diagnosis and early surveillance of these tumors is very important. VHL patients may have a deterioration of the renal function. This is not as common as in patients with polycystic kidney disease or patients with other genetic disorders. It's usually due to the fact that we take a lot of normal tissue when surgery was the main tool of treating the disease. The multiple cysts that they usually manifest do not affect significantly the renal function. So what else is, what other organs are at risk for developing tumors? A few more organs besides the brain, the retina, and the kidneys that we mentioned so far. The pancreas may develop three types of lesions: pancreatic cysts, pancreatic serous cystadenomas, or neuroendocrine tumors. Discomfort for these cysts is very rare. Usually the diagnosis is incidental. When people look at the kidneys, they also observe the pancreas in the MRIs. And from all these lesions, the only one who poses a risk for the patient is the neuroendocrine tumors, because once they reach a certain size, they have the possibility to metastasize and create metastatic disease. There are slow-growing tumors, but it's very important to keep an eye on their growth pattern. We mentioned before that on the top of the kidneys, there is this gland that produces the fight and flight hormones, or adrenaline, the metanephrines. They're called adrenal glands, and they may develop tumors that they're called pheochromocytomas or paragangliomas. These are benign, again, tumors from the nervous tissue that constitutes these glands. They may be silent, but if they release these hormones, the methanephrines and the norepinephrines and the epinephrines, people may feel the symptoms of the panic attack. They may have tachycardia, headache, diaphoresis, hypertension, and if they left untreated for a long time, because of the hypertension, the effect of these hormones of the myocardium, they may be at risk for high risk for heart disease. Lastly, there are two areas that they present more occult tumors, that they are not significantly symptomatic, but they may become, and it's worth examining them in a surveillance program. One of them is the endolymphatic sac tumor. The endolymphatic sac tumors are, again, benign tumors in the middle ear. They may be silent, but they also can give you tinnitus. They can present vertigo in the patients because the ear is something that connects a lot with our sense of balance. And if they bleed, sometimes they lead to acute hearing loss, which can be irreversible. So any first sign of symptoms from the ear should prompt us to examine the presence of an lymphatic sac tumor. And lastly, the same serous cystadenomas can present in the reproductive organs, in the epididymal area in the males, and the broad ligament next to the uterus in the female patients. Again, typically are they asymptomatic, but they can also give pain. They can give masses in the abdomen and discomfort, or masses in the epididymis, and create problems. All these organs that we mentioned before are areas of the body that patients that have VHL should look at, and there are established surveillance programs to look for the early detection of these tumors so that they can be treated accordingly. So in patients with VHL, let me mention once again that the neuroendocrine tumors is the only concern from the pancreas. These neuroendocrine tumors are usually asymptomatic during the presentation. Most of the time do not produce hormones. They are hormone non-producing. Usually they're incidentally detected in imaging, and they're very slow growing and they don't metastasize unless they reach a certain size, which is 2 centimeters in the head of the pancreas, which is the one end of the pancreas, and about 3 centimeters in the tail of the pancreas, which is the other end of the pancreas. So how do we follow these tumors in the case of VHL disease? We follow them primarily with imaging. We do MRIs of the brain, MRIs of the spine, and we do MRIs of the abdomen. People can do targeted imaging to look specifically for the kidneys or specifically for the pancreas, but usually a general imaging of the abdomen gives us information about all these areas. And what are we looking for? We're looking for the tumors that we mentioned before, which may be multifocal and bilateral. They have a solid component, the hemangioblastomas, the retinal component, kidney tumors, and the tumors of the pancreas. They may have a solid component, but they also have a cystic component. And again, most of the time they appear in multiple organs. So lastly, we follow these people. When we suspect, based on the presence of these tumors, that maybe somebody has VHL, we need to test the patients with germline testing for the identification of the mutation of the VHL. So if somebody wanted to create a referral list or a suspicion list, as our patient said before, that was not very well known at the beginning, like 20 years ago, whom should we suspect that she or he has VHL and refer? Any patient who has a early onset tumor of the ones that we mentioned. Early onset means for the geneticist less than 45 years old. So anybody who has a kidney less than 45 years old of age needs to be referred for testing. Anyone who has 2 of the tumors that we mentioned before, any of the patients that have a personal history or family history of 2 at least tumors for the VHL need to be referred for testing. Anyone who is a member of a known family history, or the family history suggests, because of the presence of the tumors, that they might have been VHL disease. And lastly, based on the prevalence of the positive genetic testing, any patient with a single pheochromocytoma, single hemangioblastoma, particularly if they're young, 45, 50 years and younger, should be referred for genetic testing. But lately, VHL has not been, has transformed from a surgical disease to a medical disease, because there is a medication that has been discovered that target the driver of these tumors. This oral medication, belzutifan, has been tried in a fundamental, in a remarkable clinical trial involving 61 VHL patients, and it was approved by FDA as a treatment of the disease in August of 2021. The results were quite remarkable. The overall response rate for the kidney tumors was 67%. 44% of the hemangioblastomas had a response. And finally, neuroendocrine tumors of the pancreas had a unprecedented and stunning 91% overall response rate. And the combination of this data means that the patients with the disease do not have to have very often surgeries right now, and they can be treated with this medication when deemed appropriate. So this medication called belzutifan is not only used in patients with VHL, but it's also used in patients that they have non-VHL, like sporadic renal cell carcinoma, not hereditary renal cell carcinoma. This is because the renal cell cancer, the garden variety renal cell carcinoma, is also driven a lot by this oncoprotein, which is called HIF2 alpha. So in unresectable, in metastatic disease, it had given a significant progression-free survival and overall response rate when it was compared with another classic medication that was standard of treatment. And now it's FDA approved as a second line of therapy in patients that they were treated before with immuno-oncologic agents, VEGF. Lately, I think the summer of 2025, this drug was also approved for FDA for treating pheochromocytomas of paragangliomas. Remember, these are tumors that we encounter in VHL patients, but this trial included patients beyond VHL, anyone who had paraganglioma and pheochromocytoma, and the patients had, in the 32% of the cases, a remarkable response. So now it's approved by FDA for patients older than 12 years old with paraganglioma and pheochromocytoma. How is this drug? Is it safe or not? This drug, belzutifan, is a very safe drug. It's actually a very easy drug to administer. I've been doing oncology and treating patients for more than 30 years, and I can say that belzutifan is probably one of the easiest drugs to administer. Patients, the main side effect of the medication is anemia. This is not a side effect, it's a non-target effect, because HIF2 alpha also is used to produce a hormone that stimulates the production of red blood cells. So patients are having anemia in about 90-30% of the cases, although severe anemia, what we call in clinical trials grade 3 anemia, is encountered only in 7 to 12% of the cases. As I mentioned before, this is because HIF2 alpha stimulates erythropoietin, this hormone that produces red cells. So if you inhibit HIF2 alpha, it's reasonable that you are going to make your patient anemic. How we treat this anemia? Primarily, we can treat it by giving back erythropoietin. This is a safe manifestation. It is not recommended necessarily officially in belzutifan by FDA, but we clinicians found very helpful, very efficient, and very safe to treat the patients with erythropoiesis supporting agents like erythropoietin and the various forms of it. You can also reduce the dose, or we can stop the medication for a while, and when this is coming, the red blood cells come back again. In very unusual circumstances of extreme emergencies, we consider transfusion of the patients, although through appropriate supervision of the patients, most of the clinicians should be able to be able in the position to avoid this. So we talk about one target lesion for one target medication for HIF2 alpha, belzutifan, but there is another medication who acts similarly to HIF2 alpha. This medication is called casdatifan and has been also tried not in VHL patients for the moment, but in renal cell carcinoma patients that has metastasis and they have heavily pretreated before. It also causes anemia, like the belzutifan. It has significant responses and partial responses and durable, stable disease in patients that they are across all the groups of risk, like high-risk patients, patients that have aggressive component, and patients that they have no aggressive component, and now is in phase 3 trials with a combination of other targeted therapies for renal cell carcinoma. I would like to hear your experience about how involved did you feel when your healthcare providers were planning the different approaches to the tumors and you were planning your treatment options, for example, surgery versus treatment with the medication?
I feel like I've been very involved because there are a lot of choices. Now we have the medicine too. So the choices are do nothing. Sometimes that is fine. Sometimes it's to start the medicine or no, go to surgery. So I've been very involved, and I think a lot of times my physicians have been so good about allowing me to have a voice in that treatment plan.
Let me ask a risky question, but I want your honest, as always, response. You experience many modalities. You mentioned at the beginning, when you experienced your life with VHL, that you had surgery, you had radiation, you've been recently treated with belzutifan as a medication. How would you compare these experiences with regards to physical symptoms and with regards with the psychological status that these treatment modalities induce to you?
Well, that's a really good question. I haven't thought about it this way, but I think um, certainly anytime you have to go and have a brain surgery, it is very risky. So we're talking about life and death scenarios, as good as the surgeons are.
Mm.
So it makes it much easier to have, and I have been very surgery averse. So it made it easier for me to have radiation, to choose that over surgery, and obviously the medicine. However, there are scenarios and conditions under which I would think a surgery might also be an option because you don't want to be on a medicine for a very long time. So I think it's a very personal choice, and it's good to have choices.
How do you navigate through these choices?
Yeah, for me, the medication was fantastic, especially at the beginning, because I saw at least an 80 some percent reduction in my tumor size. So that was amazing. Having said that, after 9 months or longer, the the the, the anemia and the sort of not having a lot of energy and so on and so forth became quite taxing, and I wanted to stop. So I haven't faced the choice to either have the medicine or have surgery yet, and so I don't know how I would choose. But I think it's a real choice. It's not it's no longer a no-brainer for me.
It sounds like you would feel very comfortable to have the medication as your first choice. Uh,
Yes,
and also you had the opportunity and the choice to stop the medication after a certain period of fatigue.
absolutely. Yeah, it's a first choice, no question.
Right. Uh, Thank you very much. Thanks about this.
So
So let's move to the last part of our discussion, in which part of our discussion I would like to emphasize that um, you had neurosurgeons who they were involved in your case. You had ophthalmologists that they were involved in your case. You had a medical oncologist, geneticists that were involved in your case. And of course, a urologist, at least in the past, that was involved in your case. I think this is an example of the fact that treatment of the patient with VHL disease is a multidisciplinary exercise. And somehow we have to have physicians that they do have this experience in their own discipline. And you as a patient, I'm sure you felt a lot of times that you interacted with all these disciplines together, and that they all have to work together to prioritize the target. In the case, let's say you have a renal cell carcinoma and a hemangioblastoma, they have to be present to monitor the response to the belzutifan, the disease progression and response in the eye by the ophthalmologist, in the brain, in the kidneys. What was your experience with having this multidisciplinary interaction, essentially, in relation with healthcare providers?
This is a topic of discussion for my family a lot. We consider ourselves very privileged to have access to the kind of care and the caliber of doctors that we have. Towards the beginning, having this condition means you have time bombs that can go off inside of your body at any time, that are just waiting to become a problem. And so when we have a scan or a test and we say, okay, no, things are okay, let's wait 6 months or a year, I was having a lot of difficulty during the 6 months or a year, just mentally managing the thought that this was happening inside me. And one wise person told me, don't you trust your doctor? And I said, yes, of course I do. And they're like, so why are you worried? They told you to come back in a year. So why are you worried? And so to me, having that relationship with the doctor where you have that trust is priceless in a situation like mine. And being able to access all the ones you talked about, whether it was the brain surgeon or one of the better retinal specialists in the country, the urologist, the facilities that are amazing, and so on and so forth, just increase that trust, and so that the mental aspect of it is a lot easier to deal with, knowing that I have access to those people.
So you would say that the relation that you establish with a healthcare provider, which is essentially a longitudinal relation with the different providers of the multidisciplinary thing, helps you to decide, and at the same time helps you to understand the pros and the cons of every approach.
Yeah. Oh, absolutely. And the fact that they talk to each other when needed
Yes.
is also very helpful.
Yeah, multidisciplinary. I would like to emphasize this and to highlight it. I mean, given this opportunity, multidisciplinary does not mean a line of physicians or healthcare providers with different specialties that you can visit as in an assembly row and exit this line as a product. It means that the team is actually talking to each other as a team, and they reach a common converging strategy that's based on the tumors that you have and based on the needs that you have and your social and psychological needs that you have, because you may be afraid of one thing more than you be afraid of the other. Talking about this, have you experienced any symptoms or side effects, but that the involvement of the healthcare providers was significant to address the side effects?
Sure. I mean, with VHL, certainly before my surgeries, I exhibited a lot of neural symptoms that required, the surgery. That was indication that no, it's time for surgery. This was before belzutifan, and so we had to decide. So that's certainly one. I've had vision issues that seeing the retinal specialist has been very helpful in addressing. And finally, while on belzutifan, just having that regular maintenance was very helpful, because when I was really starting to get more anemic, having the treatment in a timely fashion was very important.
We thank you very much for joining us. today. All these efforts and works are done for you. And I want to say that from the healthcare providers, it's very important that we have a continuous feedback from you, contribution in our research efforts, but also continuous feedback in our clinical decision making and how we can improve things in the future. Thanks very much for being with us tonight. So, since we discussed surgery versus treatment and all these things, let's sum up your experience, our experience, and what we talked today about VHL. Let me preface this by saying that our surveillance approach, at least in the MGB Cancer Institute, is that we do an annual MRI of the brain, of the spine, and the abdomen, along with an annual examination of the retina. So we observe these tumors. So what tumors we observe? We observe the tumors that they are silent, the tumors that they don't grow. We see kidney tumors that they are way less than 3 centimeters. Neuroendocrine tumors, I said that there are 2 centimeters, less than 2 centimeters in the head, less than 3 centimeters in the tail. Small pheochromocytomas that they are not growing. Retinal hemangioblastomas or small hemangioblastomas that they are more or less steady. They don't significantly grow and they don't cause any mass effect. This is kind of a quiet description. I say what we do is that we observe this through an annual surveil. When do we consider intervene with the disease, start treatment with the disease? We consider intervening with the disease when we have a growing tumor, particularly if this growing tumor has a significant slope and growth rate. So if we have a renal cell carcinoma or a hemangioblastoma that they're growing, we consider intervening and treating the patient. We keep in mind here the time frame that we have in front of us. For example, the medium response of a renal cell carcinoma to belzutifan is 11 months. The medium response of hemangioblastoma is much less, is 3 months. So in tumors in the kidney, they approach 3 centimeters. Hemangioblastomas that they are growing, there is no cutoff like in the kidneys, but if they are growing in areas that they are more prone to develop tumors because of obstruction, and we were more vigilant in neuroendocrine tumors that they are approaching the 2 centimeters in the head or 3 centimeters in the tail. We consider intervene. And my first personal choice for this intervention, in most of the times, with the consent of the patient after discussing their options and what they prefer, would be to treat them systemically with belzutifan. I have to say that most of the patients choose to have the belzutifan. There's the occasional patient that chooses to deal with a tumor in an isolated way because they do not want to be hostage of a long care treatment and visits to the hospital. But I would say that almost 98% of the patients would prefer to try the systemic therapy before going for a craniotomy. When do we choose surgery? I think that the surgery scenario is kind of more dominant when you don't have time to assess the response to the medication and there's an emergency. For example, if you have a retinal hemangioblastoma that's seriously leaking and you have a early retinal detachment or fluid under the retina or a lot of visual symptoms, then the ophthalmologist would prefer to intervene and laser this tumor than trying the effect of the belzutifan. When the hemangioblastoma is moderately to significantly symptomatic, I'm not talking about a slight headache, but moderate to significantly symptomatic, there is a hard discussion of trying the belzutifan or waiting for the effect or going to VOR. Truth is that I walked many patients back from the OR with belzutifan, but there are also cases that surgery was mandatory. When we have a patient who presents already with tumors that they're beyond the safety size, for example, more than 3 centimeters in the pancreas or more than 3 centimeters in the kidney, then in order to prevent metastasis, I would say we would prioritize surgery and then treat the rest of the tumors if they exist with belzutifan. So my mainstream of approach is keep an eye on the tumor with surveillance and then decide whether at some point that intervention, what the intervention would be. I think that most of the patients that are under surveillance will have the belzutifan and the systemic therapy as an option or available to them. It is the patient who doesn't know that has VHL, or the patient that has been lost to care, or the patient that has not been complying with the care, that will present with very advanced disease that essentially with mandate surgical intervention for the safety of the patient. I hope, at least personally, this is my philosophy. Lastly, let me leave you with some SMART goals. What are these SMART goals? First, apply VHL testing criteria to all patients presenting with VHL-associated tumors and complete appropriate genetic or specialty referral within 3 months with the goal of reducing the diagnostic delays and improving long-term patient outcomes. Incorporate multidisciplinary input into the treatment decision for VHL patients, ensuring that each patient receives a coordinated care plan within 4 weeks of evaluation. Implement shared decision-making tools during visits with VHL patients to discuss with them the surveillance, surgery, and systemic therapy options, ensuring 100% of eligible patients receive a documented counseling about risks, benefits, and side effects within 2 clinical encounters. Conduct a 14-day case review for any new enlarging lesions to guide observation versus intervention. And lastly, screen all VHL patients for quality of life concerns at least twice annually and provide referrals to supportive services within 3 days when concerns are identified. Today's program was the first of 2 activities in this series that discuss VHL. I hope you will check out the other brief case on the identification and surveillance of individual VHL patients.